I'm Catherine Santoro, Director of Policy and Development at the National Institute for Healthcare Management Foundation. And on behalf of NIHCM, welcome to our webinar today. In the United States, healthcare spending is highly concentrated, with the top 5% of spenders accounting for half of all healthcare spending. And the top 1% spend an average of $107,000 per year, for a total of $342 billion in annual spending for this population alone. Private insurers and Medicare are covering large shares of the spending for high-cost patients. Yet we also know that this population is incredibly diverse and has complex and changing healthcare needs. To help us understand how to identify high-cost, high-need patients, improve care management, and reduce costs, we've assembled a prestigious panel of experts to share their work with us today. Before we hear from them, I'd like to thank NIHCM's President and CEO, Nancy Chalkley, who led the development of today's webinar, as well as the NIHCM staff who helped convene this event today. You can find biographical information for all of our speakers, along with today's agenda and copies of slides on our website. We also invite you to live tweet during the webinar today using the hashtag #SuperSpenders. I'm now pleased to introduce our first speaker. To set the stage for us, we have Dr. Michael McGinnis, Senior Scholar at the National Academy of Medicine. He's the Leonard D. Schaefer Executive Officer and Executive Director of the Leadership Consortium for a Value and Science-Driven Health System. Dr. McGinnis has been an active frontline participant in national and international health policy and programs for more than 4 decades, and has recently led a workshop series at the National Academy on models of care for high-need patients. We're so honored to have him with us today to share this important work. Dr. McGinnis?
Thank you, Catherine, and thanks to everyone who has called in. I very much appreciate the opportunity to talk a little bit about the National Academy of Medicine discussion series. I should emphasize at the outset that I'm serving as a surrogate for Peter Long, who is the chairperson of our series planning committee, and in addition, in some respects, a warm-up for folks who know this subject much better than I, but I'm very pleased to serve in that role and join in with you in laying out some of the foundational issues that are compelling the importance of attention to this set of patients who are among the highest demand and highest need in the nation. The National Academy of Medicine is located in Washington, D.C. We're formerly the Institute of Medicine. We serve the role as a congressionally chartered advisor to the nation on healthcare, and biomedical policy, and we do so by convening studies and convening individuals and catalyzing action. This series is an example of our convening individuals who are experts in order to identify issues that are important to engage mutually and collectively. The series planning committee was chaired by Peter Long of the Blue Shield of California Foundation. The rest of the members I will not read in detail, but they're indicated here on this slide. Obviously, a number of the most prominent authorities with respect to health policy in general and policies related to high-need patients in particular. The series was motivated not only by the importance of the issue, but by the initiative of the Peterson Center on Health Care, which has been focused on identifying the most promising opportunities to engage models that work, understand what makes them work, and spread them throughout the nation. And this particular project was one which had 4 partners and 6 affiliates. The partners were the National Academy of Medicine, the Peterson Center on Healthcare, the Bipartisan Policy Center, and the Harvard School of Public Health, and you see some of the individuals represented from each of those institutions as well. I pressed the wrong button here apparently, so let's go to the next one. The cooperating foundations who we worked closely with in this effort were, in addition to the Peterson Center on Healthcare, the Commonwealth Fund, the John Hartford Foundation, the Robert Wood Johnson Foundation, and the SCAN Foundation. 5 foundations which have pledged to provide national leadership and support for work in this area for the forthcoming half dozen years or so. Who are high-need patients was the immediate motivating question, and the series addressed this in a variety of ways. First of all, looking at high cost, and you've heard Catherine underscore one of the most prominent issues in this respect, the fact that the top 1% account for 20% of the costs of healthcare in this country. The top 5% account for about half the cost. But it's important to remember, in order to inform the exploration, that cost isn't the only factor. That among the highest 10% of spenders in a given year, 60% don't have persistently high spending over a year, over a 2-year period. So only identifying individuals by the cost that they incur with a snapshot of a point in time won't be sufficient in identifying who high-need patients are. One of the other dimensions for consideration is those who have long-term needs, require sustained attention over a period of time, such as those with serious chronic conditions, multiple co-occurring conditions. Obviously, we've all seen individuals of this sort who are high-need individuals, but it's important to emphasize that just looking at the sustained duration of a particular set of issues for an individual isn't sufficient, because a significant number of patients are only transiently in high need. That is, the nature and level of needs change over time. This is important both in the identification of the needs, but especially important in the tailoring of the services that are necessary to effectively engage the problems. Another approach, which is ultimately, in many respects, the central determinant of the nature and level of the need, is functional status. That is, the variation between and among individuals in physical, mental, and emotional needs. For example, there's substantial variation in this respect among patients who may be recovering from acute injury or surgery, or having a condition that requires an intensive therapy, such as chemotherapy for cancer, or patients who have chronic addiction-related impairment, those who have long-term mobility impairment, such as a quadriplegic from an automobile accident, those who have long-term cognitive impairment, sometimes from birth, sometimes in the later stages of life, or the mid-stages of life, and those who have needs of an acute variety and a chronic variety at the end of life. In each of these circumstances, in which every one of the patients or many of the patients within these categories clearly qualify as high-need patients. There's a substantial variation in the physical, mental, and emotional needs, and clearly the interventions need to be tailored to those needs carefully and appropriately. So the successful models, which was the focus of the series, both identifying the differences that represented the characteristics of high-need patients and then identifying the models that are effective in engaging the needs of those patients. There were certain common elements in those successful models that are listed here on this slide, and they include targeting according to the level and nature of the function, harkening back to the slide just shown on the importance of functional status, tailoring the requirements, that is to say, using assessment of the nature of the care attributes important to effectively engage a particular individual's challenges, assessing the service setting that is most appropriate for a particular individual's condition, identifying the delivery features, that is the mode of delivery that's most important to be successful, and understanding and adapting the organizational culture important for the circumstances. Each of these lenses shape the effectiveness of a particular model for a particular patient. Especially important is the commonality of social services as a rate limiting or rate accelerating factor in engaging appropriately patient and care partner specific needs. And the series underscored the importance of the care partner dimension. Again, a key element in looking at the specific needs of specific patients and engaging them appropriately. In addition, with high-need patients, there are complicated and complex dimensions that require services from different loci. So unquestionably, the linkage of those services has to be similarly tailored among healthcare system, social, economic, and behavioral programs. There isn't a mold that can be used for identifying or for linking those services. And in fact, I don't need to underscore to this audience that in a system such as ours, which is characterized by silos, it's vitally important to try to break through and connect the services that are delivered to these highly vulnerable patients. And especially challenging, and we've heard from our partners from the Bipartisan Policy Center, is the issue of payment alignment. The effort overall developed what the participants called a starter taxonomy to be considered in a more systemic characterization of the match between individual circumstances and the services needed. And you see the key elements laid out here in which the taxonomy is divided into two major groups. I'm not sure why this keeps changing. One, on the top horizontal dimension, the clinical and functional groups, and then below on the horizontal dimension, the behavioral and social assessment necessary to overlay on the clinical and functional groups. And the clinical and functional groups were 6 in number: the non-elderly disabled, those with advancing illness, or often also called end-of-life patients, the frail elderly, those with major complex chronic condition, such as cancer diagnosis with a particularly high need or high intensity intervention required, those with multiple chronic conditions co-occurring, and children with complex needs. And then again, mapped on to those dimensions are the behavioral health factors and social risk factors that need to be addressed in addition to the direct therapeutic interventions for each condition. This next slide, I'm not going to go over because I don't want to eat into the time of those who are more expert in the area and can elaborate and will naturally elaborate on some of these dimensions. But it shows a sample crosswalk on the horizontal axis among the 6 groups that were identified, and on the vertical axis, a number of identified programs which were assessed in the course of the discussion series. And the final slide is a list of the important next steps to undertake in order to shift our capacity for effectiveness in addressing the needs of high-need patients from a point currently in which those approaches are typically fragmented and suffer from the homogenization of approaches, which is not effective for these patients, to where we need to be in order to provide care that is more efficient and effective, not only for these patients, but ultimately for the investment of our social resources as a society as a whole. Beginning with the spread and scale of successful care models that are laid out in a more tailored fashion according to the taxonomy that has been identified as a starter. Again, emphasizing the importance of the integration of social support and medical care. Training clinicians on the unique challenges of high-need patients, as well as the unique opportunities for linking out with therapeutic colleagues to address those challenges. The need to promote value-based payment and measures for quality, that is, accelerating and riveting the focus on the importance and the potential returns for tailoring the interventions to the circumstances of the individuals, and the importance of creating opportunities and underscoring synergy among the various stakeholders. The report of this discussion series will be issued in about a month's time, and I would encourage you, any of you who wish to follow up for more authoritative overviews, to be in touch with any of the steering group members. Thank you very much.
Thank you so much, Dr. McGinnis. We're now going to turn to learn about some care and payment models underway across the country, and we're going to begin in Michigan. Our next speaker is Dr. Jean Malwan, the Medical Director for Blue Cross Blue Shield of Michigan Value Partnerships, She's also on the family medicine faculty at the University of Michigan, where she also maintains a clinical practice. Jean?
Thank you. Good afternoon. I really appreciate the opportunity to speak today and share the work that Blue Cross Blue Shield has been supporting in Michigan. In order to effectively manage complex or high-cost patients, I think it's important to understand the root causes that lead to each unique situation, because as the previous speaker pointed out, they're really all different. We need to build a strong healthcare foundation that helps mitigate these root causes. Otherwise, we'll just be back where we started and have an ongoing stream of high-cost patients, and the situation will continue. Blue Cross Blue Shield of Michigan has developed a comprehensive set of initiatives and programs to advance population health in Michigan and achieve large-scale transformation. And I think this is really where we're at as a country, as we need to move from small pilots to really transforming care across the country. And it's, as many of you who are doing this work know, it's very challenging. The work that we've done at Blue Cross has been done in close partnership with the physician organizations and providers in Michigan. And I'm going to be presenting a brief overview of this foundational work and then focus on the work we have supported specifically related to caring for complex patients. So this slide shows an overview of the various programs that Value Partnership supports. In the center are the hospital-focused collaborative quality initiatives, which are physician-led and focus on high-cost healthcare areas. They include specialist physicians from around the state who work together to identify focus areas for their specialties. On the left are the Physician Group Incentive Program initiatives, or PGIP as we call them, where the work I'll be speaking about today belongs. PGIP contracts with over 40 physician organizations throughout Michigan, representing a high percentage of Michigan providers. PGIP involves a close partnership with the provider community, and all of these initiatives have been designed in close collaboration with providers. Physician organizations receive funding to support infrastructure and catalyze performance outcomes. Physicians individually receive funding through our value-based reimbursement program. And this slide just presents a little overview of our Patient-Centered Medical Hope program. PGIP did develop its own program, which is the largest regional program in the country, currently with over 15,000 practices designated and about 4,500 physicians. Funding is provided for both PCMH capability building as well as achieving ongoing PCMH designation status. The PCMH practices form the foundation for team-based care, including care management. And the program that I'm going to program I'm going to be speaking about today is called Provider-Delivered Care Management, and this diagram really just shows us where it resides within the suite of programs in Value Partnerships. PDCM really refers to care management that is delivered by care teams embedded in the primary care practices in close proximity to the patient's physician and other care team members. So this is a little bit more explanation on provider-delivered care management. The care managers who are involved in this program include the following personnel: registered nurses, social workers, NPs, PAs, pharmacists, dietitians, respiratory therapists, and psychologists. And they work in close proximity with primary care physicians, generally embedded inside their practices. And the physician is the lead of this multidisciplinary team. This really expands the traditional healthcare plan delivered care management, which we have a very robust program here at Blue Cross Blue Shield, but it serves to complement the work that's done internally here at Blue Cross. There are no diagnostic restrictions on on which patients can have this service. It's available to both adults and pediatric patients, and the interventions that are covered by this service include group visits, face-to-face, and telephonic visits. So this is kind of an overview of the history of the program. In 2010, we had a pilot with 5 physician organizations in Michigan, and about the time that was ending, the state of Michigan was chosen as one of the 8 states in the Multipayer Advanced Primary Care Practice Demonstration Project. And we called our version of this project the Michigan Primary Care Transformation Project. This had over 350 practices across Michigan, and it actually just ended its 5-year duration in December of last year. And in addition to my work at Blue Cross, in my University of Michigan role, I was the medical director for this project, so I was pretty involved in it right from the beginning. Now, in 2015, we also expanded this provider-delivered care management to all what is now 1,500 PCMH-designated physician practices in Michigan, and we're also planning an expansion to specialty practices mid-year this year. And this just shows Blue Cross's participation in multi-payer initiatives, and I think, as our previous speaker noted, it's just so critical that funding is aligned with the care model that you want to implement. And it really is so helpful when there are multiple payers that are supporting a common model. And the Michigan Primary Care Transformation Project really allowed us to do that starting in 2012. And as that ended, we picked up involvement in the CPC Plus demonstration project, which started this year, and also the state innovation model, which has a PCMH pillar. And those two current interventions are pretty aligned in terms of the clinical care model, and we've really worked hard to make that the case. So this next slide really just shows the location of these practices in Michigan, and there are among 37 physician organizations with 2,000 physicians that participated in this project, covering the lives of 1.2 million patients, which is about just over 10% of the covered life of the people that live in Michigan. And you can see the participating payers that were involved in this, including Medicare and Medicaid. So this diagram, which I won't go through in detail, really just shows sort of the model that we laid out for these practices. And this was developed with participating payer input, with physician input, physician organization leadership input. And these primary care practices really had a great PCMH foundation, but they really hadn't had funding for team-based care until now. So this was all pretty much new to everyone. And so we wanted to emphasize kind of the important parts of care management, which include transition care, and then special services that are available for complex patients. And then over on the right shows the infrastructure components that each practice had to have in place by the end of year one in order to continue participating in this intervention. So what we wanted to do, if those of you who are probably familiar with this care management literature and know that many of these programs that have been tested and evaluated have not been successful. So what kept me up at night at the beginning of this program was really trying to focus on care management features that were associated with positive outcomes. And I've listed them here. This was something we sort of stuck with through the whole 5 years of the project, and I think it still pretty much rings true today. But care delivery by multidisciplinary teams that's in close collaboration with the patient's care team, including the primary care physician, close attention to care transitions, careful medication reconciliation, and not just telephonic encounters, but also in-person visits. And patient selection is really, really important because, it's pretty easy to identify last year's high-cost patient, but what's really challenging is to identify next year's high-cost patient. And I think that having the PCP input on this was really quite helpful in addition to the risk stratification methods that we used. So in terms of how we developed the selection process for these practices is they were all provided with a claims-based patient list. And again, this is not just Blue Cross, but this was across all payers, which included risk score and utilization information. And then patients who were in a category of very high were also flagged for perhaps special notice, as were the dual eligibles. And then the practices were encouraged to share these lists with their PCPs and to review them and see who might be appropriate for care management. And oftentimes the patient's PCP is the one who's more aware of who might need care management before the claims system flags that. So we did not limit the patients that were managed to those that were on the list. What we found is that patient engagement was most successful if the patient's physician encouraged the patient to participate in the program, ideally doing a warm handoff to the care manager, which meant that the PCP introduced the care manager to the patient themselves. And then the care management really needed to be tailored specifically to what that member needed. And so there are various team members listed here who could work with the patient depending on the patient's needs. And that would be determined by what we call the lead care manager as well as the patient's PCP and other team members. We had an emphasis on goal setting and self-management support, found that a lot of the work really involved care coordination, and I've always said that care managers are sort of a Band-Aid on a gaping chest wound that's our healthcare system. So there was a lot of care coordination that was involved, and that was particularly true in the pediatric practices. And we also encouraged and emphasized frequent communication between care team members and the PCP. We developed a Michigan Care Management Resource Center, which initially started as a collaboration between Blue Cross and the University of Michigan. And then as this MyPICT demonstration project came up, we received additional funding from other payers, and that's ongoing through the current multi-payer projects that we're working on. And this consisted of a foundational evidence-based curriculum and also ongoing webinars and in-person sessions for the care managers, because we really found that it was very important. They had a lot of mentoring, they had a lot of ongoing training, because these people were all pretty much new to their roles. We have a Care Management Connection monthly newsletter that includes success stories, information on educational sessions coming up, as well as just helpful tips that we think might be useful to the care team. We also found that as the care managers began to do this work, there were certain areas that really came up as needing additional focus. One of them was integrating behavioral health, one was palliative care, and one was addressing social determinants of health. So we developed toolkits and special sessions to address these. And so far we've had about 850 care managers that have been trained through this program. And the website there, I don't know if you can see it, looks like it's sort of blurred by the blue, but www.micmrc.org, if anybody wanted to take a look at that. And I won't go through this, but these were just the sort of curriculum components that we used for the initial didactic curriculum. And we had a separate pediatric curriculum. The pediatric care managers went through this curriculum, but they also had separate sessions that were focused specifically on the unique needs of the pediatric population. We also developed a multipayer database that is housed at the University of Michigan, and phase 1 of this database is claims data from all the participating payers, and then phase 2, which started about a year and a half ago, also includes clinical data from EHRs. And so that allows you to not only see what an A1C level, whether it was drawn, but what the value was. And this has been really helpful. And this multi-payer database work has continued for CIM and CPC Plus too. So in terms of results, these programs are always challenging to evaluate because, you know, if you just take the cohort that had the intervention and follow them over time, you tend to just see regression to the mean, and you're not really sure if the intervention caused the savings or if their high-cost period was over. What you need to do, as all of you probably on the call know, is have a control group that's matched that does not get the intervention or manage total population costs in both a control group and the intervention group. So the evaluation that was undertaken at Blue Cross was looking at the treatment group that received care management compared to a group that did not. And what was found was that the treatment group had $144 lower PMPM medical costs than the comparison group, about 40 fewer ED visits per 1,000 members, and 40 fewer inpatient admits per 1,000 members. And the Medicare result actually was done by Research Triangle Institute, and this focused on total population costs using a matched PCMH control group that did not participate in the project. And you can see the results for Michigan that were highlighted here, about a $336 million savings over the first 2 years of the project, which was a return on investment of about 8.6. The year 3 of the evaluation, the results are pending, and we expect that they will be published later this year. So a new program that we've developed in partnership with our physician organizations and practices is called the High Intensity Care Model. And this is a program that's designed specifically for the Medicare Advantage members at Blue Cross and to target the highest cost and highest complexity patients. And to date, it's been implemented by 8 physician organizations, and it's still in the pilot phase. And this really builds on all the capabilities that I previously mentioned in the population health strategies, and it's been carried out in practices that already have care managers embedded, but we really wanted to just add a home component. So what we did, I looked at many different models and presented them to the physician organizations for review, many different home-based models around the country, and we ended up focusing on the Indiana University GRACE program because we thought that this seemed to, it had good results and it seemed to be something that could be implemented in a relatively short time. The majority of the services are home-based, and they're delivered by dedicated teams that are composed of a nurse practitioner or a registered nurse and a social worker. And the additional team members that I mentioned previously are also included in this model and are brought into the patient's care as needed. What's nice about this is the team has access to the patient's primary care team, PCP, and the electronic health records. They can get updated information on discharges and specialist visits and things like that. And emphasis is placed on a comprehensive care plan development, and information is gathered from family and caregiver as well as the patient, and really enhances the PCP's ability to manage the patient. And the training for this, which was based on the GRACE model, was also provided through CMRC, and we worked with Indiana University pretty closely on that. The targeting criteria that we used, initially we started by just targeting a number of chronic conditions. We took a number of high-risk conditions and then said if you have, X number of these, you're a candidate for this program. And what we found is that really wasn't identifying the right cohort of patients. So what we did is we refined it to include 2 components. One is the number of chronic conditions, and 2 is various measures such as utilization, total PMPM costs over the past 24 months, and also information that was gathered from the Medicare Advantage health assessment, such as patient rating of self-perceived health status and whether they reported they needed help with ADLs and things like that. So these 2 components are combined together to develop a weighted risk score. So what have we found? So the program has been very well received by physician organizations, also by patients. And, there's initially some reluctance to have someone come in the home, but we found that with the primary care physician encouraging it, and once they realized this was a nice benefit for them, they really sort of warmed up to it. And what we found is the physician organizations have found improved medication adherence and management, avoided unnecessary ED utilization, and admissions and readmissions. And it's really strengthened the patient's relationship with the PCP. We suspected it might not do that, but it actually turned out that it was a good partnership. And what it also has allowed these teams to do is guide patients into palliative care at an earlier and more appropriate place in their life. So the care managers just love this program. They're very dedicated. The organizations sometimes report that they can't get them to go home at night because they're really dedicated to their work. The cost of this program to Blue Cross Blue Shield to date has been $235 per engaged member per month. And, there's some concern that that may actually be underfunded, and some of the organizations have had to subsidize that a little bit with their own funding. So we're still exploring what the right number is. And really, it's an early program. We really need more data in order to perform a robust evaluation. So that concludes my program on the work that's going on in Michigan, and thanks very much for your attention.
Thank you so much, Jean, for sharing your great work in Michigan. Next, we'll hear about Landmark and Premera Blue Cross's collaboration in Washington State, and we're so pleased to have Adam Boehler, the CEO of Landmark, Dr. Michael Lee, Chief Medical Officer at Landmark, and Dr. John Espinola, the Executive Vice President of Healthcare Services at Premera. Adam?
Thank you. Appreciate it. So maybe to start, I'll just introduce who Landmark is and then turn it to John Espinola, Espy, as his nickname, to talk about Premera a little bit. So Landmark is the largest home-based medical group in the country. we have risk. We're a risk-based medical group for about 45,000 complex chronic patients in 10 locations across the country. And our patients spread across product lines, so Medicare Advantage, Medicaid, dual, commercial, and exchange members. The commonality among all of our patients is they are very chronically ill. We, as I mentioned, are a risk-based medical group. We don't bill fee-for-service, and we're generally aligned on the three main things. Making a difference from a medical loss ratio perspective. That's largely done through avoidance of unnecessary institutional costs. From the perspective of patient satisfaction, and then quality. That's what we care about. Our care model is in-home primary care. On the medical side, we have a behavioral focus with psych NPs and psychiatrists, a social focus with social workers, and a fairly focused advanced palliative effort as well. We're a fully employed medical group, and I think a lot of our result in what we do is our clinical model combined with a focus on risk and all of those outcomes. So that focus on risk informs who we hire, how we train our clinicians, how we measure and compensate them, even our systems, our technology. We don't use an off-the-shelf EMR because we don't care about fee-for-service billing. We use our own an open source one and do a release every 3 to 4 weeks, really driving what we care about, which is total cost of care improvement, quality, and patient satisfaction. So that's us as a medical group. Let me turn it to Espy to talk a little bit about Premera.
Thanks, Adam. Appreciate that. And good afternoon, everybody. Really appreciate your time and a chance to talk about this collaboration that I think is making a real difference for our neediest members. First, before I get much further, I want to just provide a tidbit of detail about my background. I'm a physician who's in an executive role at a Blue plan, and I'm a geriatrician. And those two things matter because the way Primeira sees itself in the world is pivoting more towards being relevant in the healthcare space, not just the healthcare coverage space. And when we think about that, our success is largely going to be driven by how we work with and through providers to achieve our objectives. And as a geriatrician, I have a strong bias in that direction and also a strong bias towards thinking about our frailest and neediest members. And that comes into play in just a minute in our conversation. The next slide that we're going to show here, I think, if I can advance, there we go, is just a little bit of background on Primeira. We're a large regional Blue in the Pacific Northwest, where today it is sunny, for all those who are in other parts of the country and believe that it rains all the time. And we cover 2 big states, Alaska and Washington, and we're the largest commercial payer in both of those. We have a new business in Medicare Advantage as well. We've been in that now for 3 years, and we have a close collaboration with Landmark across both of these lines of business, commercial and Medicare. On this next slide, I want to frame up for all of you how we think about the problems in healthcare, and these are really driven by what we hear from our members. Our members always tell us over and over again, and this is whether it's an individual member or an employer customer, the problems are the same. They're paying too much for what they get. And that's because too often they don't get the care they need. Too often they get care that they do not need, and that can be harmful and, of course, wasteful. And too often their experience is less than they want or deserve as just human beings in the process. And for our sickest members, these problems are especially acute. They may not be mobile. They may be frail. They may have multiple touch points with the delivery system that are uncoordinated, and care may get lost in handoffs. And they often will have very complex communication needs that are unmet by brief episodic encounters with busy clinicians in the office. Another consequence of this is that they often have redundant, poorly coordinated care, and that can lead to waste and harm. And from an experience perspective, because a lot of these folks are not as mobile as they might hope to be, or because they're frail and sick and the burden associated with mobility is so great, their experience just really isn't that good. They're working with a system that is very provider-centric and not very patient-centric. And so for that, their experience is really suboptimal a lot of the time. And when we look at our sickest membership in Washington State and we do an assessment of what the care delivery system can offer, we see that these folks have pretty limited options. There's been very little investment in home-based care models to serve these neediest patients. I know that from my own experience as a clinician working in this state for quite some time and doing that work. I was often the only one around in the community doing it. So when we were looking to serve these people better, we were seeking to do so with an innovative provider. And after working with those in the community in our network who didn't really have the ability to extend themselves into the community in this way, Landmark came our way, and from my perspective as a geriatrician and also based on the needs of our customers, it was an easy decision to make to partner with Landmark across both commercial and Medicare lines of business. Here you can see on this next slide a little bit about what our thinking was. Clearly, Adam's leadership as well as his clinical team, they have deep experience in this world and great passion around it. And the clinical model is a robust one. As you heard Dr. McGinnis say, these folks have complex needs, biopsychosocial model. There are other ways, other paradigms that people use to describe it. But the bottom line is considering all of their social environment, their financial needs, their cognitive status, their physical environment, all these things are important when understanding how best to serve them. And of course, as Adam mentioned, the clinical model is grounded in focusing on results around quality, risk adjustment, and avoidable cost, and bringing the model to the patient, so an exceptionally patient-centric model. They've got the technology and scalability to do things that other providers can't do. And on the technology side, what I am always intrigued by is the fact that they are working to standardize the way they deliver care so it's consistent to ensure people do get the care they need from an assessment, screening, and treatment perspective. And they have the ability to grow because Adam is willing to invest in his organization with boots on the ground. You heard Adam mention about the way they work. They don't bill fee-for-service, so we had an ability to work with them to really carefully align incentives in a way that made sense so that we both win when the best thing and right thing is done for the patient. And what's very important when introducing a new provider like a Landmark to the community, when you're a health plan that has deep and long-standing relationships with your provider network, is you want to make sure you don't disrupt your network relationships. And Adam's team and our team worked very carefully to introduce Landmark to the community, establish expectations with our network providers about how communication would occur, how referrals could be made, and really establish boundaries around the role of Landmark versus the role of our network providers. In some cases, the network provider would retain primary care responsibility. In some cases, those providers would recognize that the best path forward was to let Landmark step into that role. But Landmark's flexibility around that was instrumental to us really encountering very little noise or disruption with our standing network. So those are some key factors that led us to choose. And Adam's going to talk a little more about Landmark itself and their experience, and then I'll come back and talk a little bit more about what we have seen over the past year and a half since we've implemented Landmark. Go ahead, Adam.
Thanks, Espy. Really the next slide talks overview of Landmark, and I won't repeat what I've said. I think that when I think about our success or factors for success in driving results, and again, ultimately, we judge our success on the basis of, significant reduction of unnecessary institutional spend, quality of our patients, both in terms of measures as well as in their lives, and satisfaction. Our belief is if we're able to delight our patients in a business model that works, then we've done something exceptional. The key for us, I think, has been being a fully employed group, being 24/7. About 15 to 20% of our visits are urgent visits that happen anytime in the middle of the night. And so that would be, a 94-year-old at 2 a.m. With flu-like symptoms. We'll go there, sit with her, stick and give fluids, IV fluids. And the cost of that delivery is not cheap, but it's much better cost-wise and also quality-wise for that patient, for us to be there with her in the evening. I think so that's been key to us, and I'll talk through some of the results. The other thing has been the infrastructure. As I said, so important to us is our technology, our process, our training, our hiring, and our compensation methodology. It makes a big difference when everything is aligned toward one specific goal, and it lets us really drive performance in those areas. In terms of patients, what we do, we take risk over relatively long periods, 5-6 year periods. We take longitudinal risk. And you may imagine the patients we're looking for where we can make a difference are not going to get better. And in a way, it's a matter of time in terms of what will happen eventually. Every patient that we see is sick enough where it's worthwhile investing in a number of visits, getting them to know our 24/7 capability, documenting them, and being with them. The key then is how do you optimize your clinical resources in the short term? And for us, since we're seeing patients actively, the short term is the next 30 to 90 days, is in the immediate. And what we do there is we have a proprietary model to tell us likelihood of hospitalization in the next 90 days. That's on the basis of claims data, pharmacy data, and our own EMR data. And then we also bring in our own, we call them HFAs or human factor assessments, to judge the clinical acuity in the immediate term, and that will determine the stream at that given moment in terms of how often and what resources are allocated. That combination of kind of a longitudinal approach and then in the short term, a focused clinical approach, I think has made a significant difference. And instead of having patients coming in and out, they're always in because this patient base, as I said, is a matter of time. They're very sick. But we don't spread resources like peanut butter across them. We optimize within there based on the immediate need at that given time. I think that's been important. Shifting to the next slide, it shows you a little bit of a picture of what Landmark looks like today. And I'll see if it's not shifting on my screen. I'll hit it again. But it will show you, there we go. I hope I didn't go too far. Maybe mine's slow. It will show you a map of what we look like. Let's see, I'm not sure that's popping. Can you guys see, are you able to see slide 6? Maybe it's not hitting. Can you see that?
I can see it.
Okay, good. Maybe it's just not updating on my screen. That's okay. So in slide 6, you can see our footprint today. It's actually an old slide. I'm just recognizing, looking at it today. We're now over 100,000 visits. Some of it says Central PA launching. That's launched. But it gives you a picture of us today and where we are. Generally, we're looking to partner in areas where there's some level of density of complex chronic patients. Now, it doesn't need to be a major metro area. Albany, New York is not exactly, I don't know what tier city that is. I'm from there, so I'm allowed to say things like that about them. But so just having some level within an hour's drive time is important. The other thing that's been important in our expansion here, and SB alluded to this, has been our partnership model with PCPs and market. We have not found necessary or helpful to push somebody out of a relationship with their PCP. That's usually not the issue. The issue is that office-based infrastructure doesn't have the ability or time, really, to spend with this patient base. And I will also say, beyond that, folks don't take care of themselves as much as they should, or else we'd all be a lot healthier. And in this patient base, they're not going to come into the doctor's office 15 to 20 times a year because they just don't do that. And so I'd liken it a bit like a trainer. If you're working out, you work out a lot more if somebody comes to you. This is a population that's well worth bringing care directly to them at any time. And so the nice aspect, obviously, is concierge care when they need it for free. If you look at the next slide, it's just a picture of our technology. I won't dwell because of time much on that, but it is custom developed specifically for what we do, and it lets us, because we have control, really push things out. And I'll give you a quick example, which is if we notice in market that hospice referrals are down or that they're not happening, and this is actually a real example where we said, okay, if we don't have an end-of-life conversation by the second visit, you can't close out the clinical record or you need an explanation. It lets us then see who's having those discussions and whether there really are advanced directives being established, and if some folks are not. And a lot of times that would let us zoom in and say, okay, these doctors in market aren't having those discussions. Why? Are they not comfortable having them? Is it not appropriate clinically? And that let us start to look and see who's doing, who's not, and have those conversations. So the ability to have that flexibility to identify there's a sub-metric that's just not adding up here, and then how it affects quality and admissions is an important one for us, and why we have our technology. Imagine Technologies is the name of our subsidiary that does it. The next slide, I'll actually turn to Dr. Lee, comment a little bit about results across the country, which has started to become fairly uniform as we reach maturity in our markets. So let me turn it to you, Dr. Lee.
Thank you, Adam. Hi, everyone. I'm Mike Lee. I'm the Chief Medical Officer of Landmark, and just wanted to state that Landmark isn't just about doing house calls, but they have a very strong bent towards performing interventions and very intensive services in the home to really stabilize these patients in place and allow them to stay in their place of residence. As Adam had said, about 15 to 20% of patients do call us for unscheduled urgent visits, and we're able to go out to the home 24/7 in person with a doc or NP or PA and really be able to do very meaningful interventions such as checking blood work, starting IVs, giving Lasix, Rocephin, Solumedrol, inserting catheters and the like. And just to be able to illustrate that, just wanted to share a story about a patient in one of our early markets. A 75-year-old male who had a history of metastatic lung cancer who was on chemotherapy, who 3 months prior to Landmark engaging with him had abdominal pain and actually was seen in the hospital for that with abdominal pain, nausea, and vomiting, and was admitted for observation, but unfortunately caught a hospital-acquired infection and ended up spending almost a month in the hospital and the nursing home before coming back to the home, and just completely wiped him out. After Landmark engaged the patient, we got the very same sort of symptoms, but the difference was that we were able to check the labs there in the home, and his white count was normal, and his labs didn't show any sort of obstructive pattern, but he was dehydrated. So we placed an IV there. We hung a bag of saline. He had pain, and so we aggressively treated his pain symptoms and his nausea and vomiting, and he was able to stay in the home. Now, what we also realized after spending more time with him was that no one had really spent significant time discussing advanced care planning with him, despite his advanced cancer stage. And in talking to him, his real goal was to be able to stay at home because his granddaughter came by and visited him every day after preschool, and that was the highlight of his day. And so, in accordance with his goals, we really focused on keeping him at home, and we ultimately were able to talk to him about palliative and hospice care, and he was able to transition to more supportive care and passed away in the home without any further hospitalizations, really in accordance with his goals. And so that's really kind of the a bit of the essence of the Landmark model. And The slide that Adam's showing talks to some of our experience in terms of our impact on admissions. And in our most mature markets in upstate New York, we have over 2 years of experience. What we're seeing is that by being able to do these urgent interventions, but also being able to, after you get your arms around them and educate them on health literacy and educate the caregivers, really being proactive about preventing hospitalizations. You can see that with tenure, on our engaged population, we're having an impact, 30, 40, 50% reduction from the baseline in terms of admits per 1,000. So, very significant, because for this population, if they're admitted a couple times a year, their risk of mortality increases dramatically. And so you can see that, there's a big impact by being very proactive and very interventional in the home for these patients on admissions. So the next slide talks a bit to our impact on medical loss ratio. And you can imagine these patients are very high cost, often over 100% medical loss ratio for patients that are with, 6, 7 chronic conditions. And what we've seen over time is that through the impact on admissions, plus we're in the home, we're able to capture accurately the diagnoses and all of the HCCs that are appropriately there in the charting, that we've been able to drive significant impact on medical loss ratio. And so these patients who historically have been, well over 100% in terms of medical loss ratio are down into, over a span of a couple of years, down into the 70s in terms of medical loss ratio. So it's a significant impact in terms of not just, the admissions, but also, the revenue impact.
And, this population, as some folks may know, if you look at it, typically when we're taking risk, because risk adjustment kind of breaks down at the very high end, and my belief for why that happens is because the risk adjustment model in Medicare is a prospective model versus a concurrent model. And when you have more deterioration quickly, things that are based on last year don't quite catch up. And so very unusual for us in any medical group or payer that we work with to see anybody under 100%. If we were under normal risk adjustment, if things were normalized in a concurrent model, we've looked at that, we'd be running in the 50s to low 60s. But we're very happy, because what I would say is when we initially partner with plans, one of their concerns is attracting poor risk, possibly, right? And as we move to a portion where you're under 100%, plans are much more flexible and able to really actually market this as a benefit where they otherwise may not. And so I think that's been very helpful. Oh, next slide, sorry.
And also, on the next slide, one of the areas that we feel really proud about is being able to have a significant impact on quality for the patient population. And so you can imagine for a very polychronic population, it's much harder to control, for some of the control measures and maintain compliance for them. But this slide talks to a composite of some of the quality metrics that our health plans ask us to focus on in our mature markets, and they typically would set a goal which is 5 to 10% above the baseline of what that population was historically doing. And you can see that across the board, and especially for the control measures, we far surpassed this already improved goal for this population, and we're able to hit 5-star metrics for the goal, for the targets that our health plans had. So, significant impact not just on utilization, but also improving patient quality scores as also. And going on to the next slide, obviously, this is essentially concierge-level care brought to the home 24/7, not for patients who can afford it, but those patients who actually really need it the most. And this slide talks to the results of a third-party survey that's done for patients, and a couple of things that really stand out. Obviously, it's a program where we're there when they need them, and so very, very highly satisfied. And the patient response rate for a mailed survey was over 50% of patients actually returned the survey, and actually in our most mature markets, it was a 76% rate of patients returning in the survey, so outstanding stickiness. And the Net Promoter Score of 93% is also, we feel, also very tremendous, in that the patients really see the value, and when asked, do they think that the Landmark program helped them to avoid a hospitalization or ER visit, vast majority, 97%, said that they believe that this did. So again, a very satisfied patient population. And just one other thing that I'll add is that, when we look overall, one of the other sort of quality scores that we're happy about is that when we look at mortality rate for the population, I think by keeping these patients, out of the hospital and from revolving back and forth in and out of the hospital, and giving them all of their options as their disease progresses, we've seen a significant decrease in mortality rate for the patient population, on the order of 15 to 20% decrease in mortality rate, depending on the market. So again, I think we're proud that patients are living longer with higher quality scores at lower cost, but also just a very satisfied population.
Let me turn it now to Aspi.
Okay, and I'll just wrap up real quick because I know we got to get back on track here. So you heard some of the results from a numerical perspective. I thought I would share a little bit from a health plan perspective about our experience working with Landmark and give a little bit of insight into how it works. Really, this is a very close collaboration. Premera is doing a lot of the analytical work to identify our highest risk members, developing that algorithm and methodology in collaboration with Landmark. Once identified, our members are notified of their eligibility, and our clinical team will even reach out to them, especially those members who are actively engaged with our case management team. And that helps prime the pump for receptivity, so that when Landmark reaches out, that member is not surprised, they're not confused, they understand what Landmark's role is, and helps increase the level of engagement. What we have seen so far is that the adoption rate is quite high. There are some people who will say not now, maybe later, but for the most part we're seeing much higher than expected engagement rates, and then for those who do engage, they stay engaged. We're also seeing good coordination of care across the behavioral health and other domains of care that are required to serve these folks. They have complex needs that are not served by only one clinician. It's usually important to engage others. And also our Premera's clinical team engaged in case management will also help coordinate social and community services to complement what's going on. Very importantly, what we see is, and Dr. Lee mentioned this, the members love the program. So as much as it's helping with their clinical status, it's importantly helping with their psychosocial status as well, knowing that they have someone that they can rely on and depend on, knowing that they have an ally who's there when they need them on their terms. And that's a pretty transformative thing in healthcare today. So that's one of the key things we really appreciate about it. We are seeing favorable impact on the Medicare side. We see essentially a budget-neutral impact on the commercial side. So we do invest in this, and it does cover the investment. We're not yet seeing ROI on the commercial side, but that doesn't mean that we would make a change. It's a different population and a little harder to get at than the Medicare side. And I think in the interest of time, I'm going to leave it at that and allow Clare to get her presentation underway.
Thank you all so much. Our next and final speaker is Clare Wrobel, Director of Payment Reform Models for the Healthcare Transformation Task Force. They've been working with their members to improve care for high-cost patients, and I'll turn it over to her so we can learn more about their work and the future landscape for value-based payment.
And so as Catherine mentioned, I'm going to wrap up this set of presentations by providing a bit of an industry perspective on the current policy environment and how that impacts value-based care delivery for the high-needs, high-cost population, and really, as we see it, the future of payment models that will support care management services for these populations and consumers. So a bit more about our group. Our mission is really to achieve results in value-based care. The Healthcare Transformation Task Force, it consists of patients, payers, providers, and purchasers that are all committed to moving into value-based payment arrangements and have made that a commitment to move 75% of their respective businesses into these arrangements by 2020. Our members represent both regional and national organizations that have been early adopters in value-based clinical care models, including Blue Cross Blue Shield of Michigan, which is represented on this panel as well, and have really been pushing, again, the movement towards value models and incorporate better incorporation of care management for the high-needs, high-cost population. One of our areas of focus has been on identifying successful models for improving care for high-cost patients, and to that end, we released a series of white papers that address the steps that organizations have taken. As the other presenters have noted today, there is a step of proactively identifying those patients, developing care management programs to specifically meet their unique needs, and utilizing supportive payment mechanisms to sustain those programs over time, with a highlight on multi-payer approaches to sustaining care management, as was highlighted in the Blue Cross Blue Shield of Michigan case study. Our next area of focus for this work will be in identifying successful mechanisms for integrating social services into those existing care management programs and addressing the social determinants of health. And to that end, we will be hosting a webinar next Tuesday, May 23rd, discussing a framework and highlighting a case study in that area. But what I want to talk about for the next couple minutes here is what we're paying attention to on the policy horizon. Obviously, the ability to provide high-quality care for this population is dependent on coverage and access to care. And I think if one word could describe the current landscape and environment in Washington, D.C. right now related to this, it's really uncertainty. And so what we're watching now is really all eyes on the Senate. The House will be ultimately sending that bill to the Senate of the ACA bill for review. While they're awaiting the CBO score at this time, the Senate has still started a working group to define what that would look like. We're seeing greater participation in that discussion from governors. Governors, and especially those Republican governors who have expanded Medicaid and that understand a bit more about how their Medicaid expansion programs have been working in their states, are pushing the Republicans in the Senate to consider greater flexibilities for states to continue to expand Medicaid for the population, and obviously one that is impacted greatly by the care management programs discussed today. That while the value agenda itself, when we think about value-based payment models to support transformed care delivery, while not directly addressed in the ACA and repeal and replace discussions to date, there's certainly several factors that will indirectly impact those efforts, and coverage being just one of them. And that coverage, while there has been recent analysis specifically from the Kaiser Family Foundation identifying that there would be direct impact on about 6.3 million people that have had a gap in coverage in 2015 that would put them at risk for higher premiums and potentially push them out of coverage, we're still trying to determine based on what the final bill will look like exactly what that impact would be. But that, again, going back to that keyword uncertainty, is having a lot of impact on how the private sector and provider organizations are finding an ability to make reasonable investments in the value-based care space. While I'll speak to in a minute to the continued advancement through MACRA, which retains bipartisan support, Another interesting policy development has been in the Chronic Care Act, which was reintroduced in the Senate and voted unanimously out of committee yesterday. This is a bill that would bolster care management for Medicare beneficiaries with chronic conditions. One of the provisions that was introduced included a beneficiary incentive program, which would encourage greater participation in preventive care, and a number of other provisions that would improve the accountable care organization model, the Medicare accountable care organization model, which again will impact care delivery programs for this population. So the opportunity to move the value agenda back up the priority list is really here at this time. The other big piece here that's moving Medicare and the rest of the delivery system into a more value-driven formula is really MACRA and the incentives to drive towards better coordination of care for high-needs Medicare beneficiaries through incentives to move into advanced alternative payment models. We've noted that the pick your pace for MIPS in 2017 could have a varying degree of provide varying degrees of motivation for providers to continue along their value-based transformation journey. There's also been about 2/3 of Medicare providers that have been exempt from MIPS. So what does that do in terms of continuing the momentum, encouraging and incentivizing providers to adopt new care management models? We're starting to see at CMS the leadership and HHS, the leadership team fill out, and some of those policy priorities, gain more shape. One of those is on focusing on reducing the provider burden through regulatory reform. As communicated by Secretary Price and Administrator Verma in public statements and recent requests for information, this is really a central theme from this administration. And again, we'll see how that plays out as it relates to the other policy items for discussion. We're also looking at how the new policymakers will utilize the Center for Medicare and Medicaid Innovation, which is invested in private sector and provider transformation and adoption of value-based payment models that support better care management and care delivery for this population. It has proved to be a valuable testing laboratory, and we believe that while there may be some pruning of the tree, that this has moved away from being a lightning rod and is really going to provide that laboratory for the Republican administration to test their agenda. Part of this has also been expressed as a desire to test more state-based innovation, Medicaid participation in several of these innovative payment models that have been mentioned today on the webinar, including the Comprehensive Primary Care Program, has been really critical to advancing multi-payer adoption of value-based payment models that encourage greater care coordination. These types of additional flexibilities built into the Medicaid program is something that we'll be looking for. Also, whether or not this administration makes a decision on encouraging mandatory versus voluntary bundled payment models. We know that Secretary Price has in the past not been supportive of mandatory models, and the new episode payment models, which were addressing cardiac and orthopedic episodes, were delayed. Yesterday, it was announced that they'll be delayed until January 1st of next year. And we do see a proposed rule pending OMB review that could modify the mandatory nature of those models. So we're basically looking at this to see what's the direction, what's the signal that we're getting from the administration on their support for continuing the investments in value-based payment models. So the other area that we think could be an interesting mechanism for bringing additional payment models to support care management programs would be through the PTAC, or the Physician-Focused Payment Model Technical Advisory Committee. This is a vehicle that was introduced by MACRA, which allows private stakeholders to bring physician-focused alternate payment models forward for consideration for CMS to take on and test. The PTAC reviewed its first proposals and made decision on its first proposals in April, recommending 2 of those models to move forward, and one of those specifically addressing chronic conditions that were associated with high costs. So this is really a vehicle that could, for the private sector, again, could bring promising models forward for testing at a greater scale within the Medicare program. And how CMS at this point proceeds on those recommendations is an open question, but something that we're watching closely. So just to wrap up, the current environment at this point really does affect the existing momentum, as I've mentioned. The prior presentations demonstrated that this is really hard work to set up these types of programs, and it takes time, investment from providers to implement, and especially these programs that are addressing the unique needs of a high-need, high-cost population. Medicare and Medicaid participation in these new payment models to support those programs has been critical to supporting that implementation and transforming the delivery system, and sustaining that investment is really now the question. And for new entrants to value-based payment models, it again is a question of whether or not they have the certainty in place to start. So what we're asking for, and as an industry group that is supportive of continuing this transformation, we're continuing to educate policymakers to promote that momentum, maintaining the rhythm from the private sector so that the public sector can stay engaged, and asking for additional signals from policymakers for support for value-based payments so the marketplace doesn't chill to ongoing innovation and improved care for high-needs, high-cost patients. And so with that, I'll turn it back and say thank you for listening, and to the other presenters for the terrific work they've been doing to improve care for this population.
Great. Thank you, Claire, and thank you to everyone for all those rich presentations. I know that we went a little long into our Q&A period, but we'll try to get through a few questions, and I'm sure our speakers would also be happy to connect with folks offline for some more specific technical questions. Why don't we, if all the speakers want to come off of mute, we'll take a couple minutes and try to address a few of these questions. We had a few questions coming in about, integrating with community-based organizations offering, these social services, social supports, non-medical benefits, and Claire had touched on this Chronic Care Act and the potential for, payment through Medicare Advantage. Could you all talk about, to what extent, are you offering or supporting these types of benefits now, or how will, this payment through Medicare Advantage facilitate that going forward? Anyone can start.
Yeah, I'm sorry, this is Jean. Could you kind of rephrase the question? I'm not sure exactly what the question is asking. Is it asking about benefits paid by the insurer, or?
I think they're asking to what extent are you working with any community-based organizations, or are you providing any sort of non-medical benefits that people might need in this population? I think, Claire had mentioned this. I don't know, Claire, if you want to elaborate on what they're proposing in the Chronic Care Act?
It would provide a little bit more information, at least from what we've been hearing from our members in this area, and that is on the social service integration side. Kind of one of the first considerations for partnering with community-based organizations is what form that might take. So what exactly is the governance structure, which is going to look a little bit different from traditional clinical partnership models. And so that's one of the first things that we've been looking at. What are those successful governance structures that will encourage better coordination between traditional care delivery and non-clinical care services that address social determinants of health? And we think that there are some interesting models that will be supported through models that the Innovation Center has introduced, such as the Accountable Communities for Health model, and some of the additional flexibilities that accountable care organizations, for example, have to partner with and pay for services that are not directly billable today by Medicare. So again, I think there are some promising models. We'd be interested to hear if any of those resonate with the other investors on the line.
So this is Adam from Landmark. In terms of us, because we're taking risk, generally on managed care patients is our model because we don't do fee-for-service. We don't actually need difference in payment for the most part to do what we need to do. I mean, our social worker and behavioral health focus is there because, in essence, it's the right thing to do to reduce, utilization and improve quality for our membership. That is obviously different on the traditional Medicare side. We're big fans of and have been involved in an effort called APGs or Advanced Physician Groups. It kind of same thing as a preferred physician network. I think that's come up in health affairs as well. That allows physician groups to take direct risk from Medicare. And I think that would address that from a payment perspective, too. I think one of the purities on managed care for us in terms of taking risk is we just focus on what makes a difference versus what sounds good, and we don't need additional payment because if it didn't work, we wouldn't do it. And so hopefully, but on traditional Medicare, that's obviously not the case. And so we're hopeful over time that direct risk to physician groups, is a possibility.
Yeah, and this is Jean. I'll just add to that. What we found with the multi-payer interventions that we've been participating in Michigan is that many of the payments are not fee-for-service. They're like PMPM payments that are not really, it's not really dictated how that money's used. And so we've had some groups, like the state innovation model has had groups that got together and sort of talked about how we were going to use this money. And there is, I agree, there's a huge need for these community resources to have funding. And traditionally the funding's all been on the medical side. So what Blue Cross Blue Shield commercial does to fund this is value-based reimbursement that goes to the providers so that they can actually support some of these services, but not paying for them directly at this time.
Great, thank you. Also a question for Landmark. You're working with the diverse population. You mentioned the Medicaid, the duals, commercial. How do you adapt your model across the different populations, and sort of how are you, adapting to work in maybe more, lower income or people with lower health literacy in different parts of the country?
Yeah, so especially as we are taking patients with the Medicaid and duals, we do find a lot more lower socioeconomic status in patients who have less resource availability. And so, what we do find is that, on those sorts of populations, Medicaid and duals in particular, that there's much higher behavioral health and social determinants burden. And so what we've done for those particular markets is that, in terms of our staffing ratios, we have a much higher ratio of social workers as well as psych NPs, and also have, needing to hire, addictionologists because substance use disorder is much more prevalent in this sort of population. And so really, I think for the commercial, the Medicaid, the duals, in a way, you have much more of that behavioral health burden. And so really having kind of a very robust internal team that can help to manage that in place, because I think you recognize that those resources are pretty scarce in the communities.
Yeah.
Great. Thank you. Jean, there's a question for you about, how are you communicating to enrollees about your programs at the beginning of their relationship with Blue Cross Blue Shield of Michigan? I think it was when you were talking about the PBCM program, but I think kind of curious, what's coming from the physician versus what's coming from the plan and the care managers.
Yeah, well, this communication to the members as they're enrolling in Blue Cross is not does not uniformly include these programs, either the PDCM or the HICM program, because they're only offered to a subset of patients at this time. For instance, patients that are in patient-centered medical homes. So what we have done is we've developed brochures in partnership with our physician organizations that we've asked them to put in the practices and have the care managers give those out or have them in the waiting room that actually talk about this service and, reassure patients that it's a covered benefit and how it could benefit them. So that's kind of the way that we've been, direct marketing to patients that are actually eligible for the service at this time.
Okay, great. It's almost 4 o'clock, so we are going to wrap up. We do still have a few more questions that were submitted, but if it's okay with the speakers, I'll share those offline for you to follow up with folks. I do want to thank our excellent panel of speakers for joining us today and sharing these great presentations, and ask our audience to take a moment to share some feedback with us by completing a brief survey that you can access by clicking on the survey button on the bottom of your screen. You can visit our website for additional resources from NIHCM, including our healthcare concentration chart story. There's also information on an upcoming Alliance for Health Reform webinar that we're supporting through a grant that's going to discuss the future of Medicaid. So thank you all again. Thank you to our speakers and to our audience for joining us today.